In this presentation, we shall discuss the hormones secreted by the hypothalamus and the pituitary gland. The aim of this presentation is for you to gain an understanding of the hormones secreted by the hypothalamus and the pituitary gland, and by the end of the session, you should be able to discuss the following aspects of hypothalamic and pituitary glands: their chemistry, synthesis, functions, control of secretions, and the common disorders associated with the pituitary gland. We shall start with a basic introduction to endocrinology, and as you may know, that hormones are chemical mediators produced by specialized endocrine glands. Endocrine glands are ductless glands and pour their secretions directly into the blood. This is different to the exocrine glands such as the salivary glands, which utilize ducts to transport their secretions to their target sites. Of the several endocrine glands, pituitary gland is considered to be the master endocrine gland of the body, and we shall discuss this in detail in a moment. The other endocrine gland located in the brain is the pineal gland in the epithalamus, which produces melatonin, responsible for regulation of the sleep pattern. The thyroid gland located in the anterior neck secretes thyroid hormones which regulate body metabolism. In addition, the parafollicular cells of the thyroid gland secrete a hormone known as calcitonin, which regulates blood calcium. The parathyroid glands, 4 in number, located on the dorsal aspect of the thyroid gland, secrete a hormone known as parathormone, which is also responsible for regulation of the blood calcium. The pancreas is a mixed gland and has both endocrine as well as exocrine portions. The endocrine pancreas secretes insulin and glucagon, which regulate blood glucose. The adrenal glands are paired glands located on the superior poles of the kidneys and have an outer cortex and an inner medulla. The adrenal cortex secretes 3 groups of hormones, namely glucocorticoids, mineralocorticoids, and the androgens, while the adrenal medulla secretes adrenaline as well as noradrenaline. Finally, the sex hormones are secreted by the testes in the males and ovaries in the females. The testes produce testosterone while the ovaries produce estrogen and progesterone. In addition to these primary endocrine organs, there are several organs with secondary endocrine functions. Examples are thymus, which produces a hormone known as thymosin, and kidneys, which produce a hormone known as renin. As mentioned before, the pituitary gland is considered to be the master endocrine gland of the body because of the variety of hormones it secretes. The pituitary gland is housed in the hypophyseal fossa in the sphenoid bone, and superiorly it is related to the hypothalamus, to which it is connected with a stalk known as the infundibulum. The pituitary gland itself is composed of 2 distinct regions: the anterior pituitary, also known as adenohypophysis because of its similarity with the glandular tissue. Adeno is to do with the glands. And the posterior pituitary, which is also known as neurohypophysis because its structure is similar to the neuronal tissue. The anterior pituitary secretes 6 different hormones which are synthesized, stored, and secreted by the anterior pituitary. The posterior pituitary, on the other hand, secretes 2 hormones, but these hormones are actually synthesized in the hypothalamus and then transported through the local blood vessels into the posterior pituitary, where they are stored and secreted. Now we shall look at the hormones of the anterior and posterior pituitary in a bit more detail in the subsequent slides. The hypothalamus synthesizes a variety of hormones which exert control over the secretion of hormones from the anterior pituitary. These hormones, known as releasing and inhibitory factors of the hypothalamus, are transported through the hypothalamic-hypophyseal blood vessels, which are the blood vessels connecting the hypothalamus with the pituitary gland, also known as hypophysis. So hypothalamic-hypophyseal blood vessels, and they are transported to the anterior pituitary where they control the secretion of hormones from the anterior pituitary. The anterior pituitary gland produces 6 hormones, and this table provides a breakdown of different cell types in the anterior pituitary gland, their relative population, their product, and their target tissues. Somatotrophs are the predominant cell type in the anterior pituitary, constituting 40 to 50% of the population. They synthesize growth hormone, which targets all tissues of the body and promotes generalized growth, and it also targets liver metabolism. Corticotrophs, 15 to 20%, produce adrenocorticotropin hormone, also known as ACTH, which targets the adrenal gland and more specifically the adrenal cortex for the stimulation of glucocorticoid release from the adrenal cortex. It also targets adipocytes, leading to the release of fatty acids from the fat stores in the body so that fats can be utilized for energy production. Finally, ACTH also stimulates melanocytes throughout the body. Thyrotrophs, 3 to 5%, synthesize thyroid-stimulating hormone, which stimulates the thyroid gland to release the thyroid hormones. Gonadotrophs, 10 to 15%, produce 2 hormones, luteinizing hormone and follicle-stimulating hormone, which target the sex organs in the males and females. So they lead to the production of hormones by the ovaries in the female, estrogen and progesterone, and in the male, they stimulate the testes to produce testosterone. Finally, the lactotrophs, 10 to 15%, synthesize prolactin, which targets the breast tissue, promoting the growth of the mammary glands, and also has actions on the gonads. As mentioned before, the hypothalamus controls the secretion of hormones from the anterior pituitary, and hypothalamic neurohormones act on the adenohypophysis to stimulate or inhibit synthesis and release of anterior pituitary hormones. This table lists different hypothalamic hormones and their effect on the pituitary gland. The corticotropin releasing hormone, known as CRH, stimulates ACTH excretion from the anterior pituitary. Similarly, thyrotropin releasing hormone, TRH, stimulates TSH and prolactin secretion from the anterior pituitary. Growth hormone releasing hormone stimulates growth hormone secretion, while somatostatin, also known as growth hormone inhibitory hormone, inhibits growth hormone secretion from the anterior pituitary. We also have gonadotropin releasing hormone, also known as luteinizing hormone releasing hormone, which stimulates luteinizing hormone and follicle stimulating hormone secretion from the anterior pituitary. And finally, prolactin inhibitory hormone inhibits prolactin secretion from the anterior pituitary. The secretion of hormones from the hypothalamus and the anterior pituitary are controlled by a negative feedback mechanism. And in order to understand this, we shall use one example. So for example, during conditions of stress such as trauma, major surgery, the hypothalamus may be stimulated to release CRH, which is corticotropin releasing hormone, which in turn will act on the anterior pituitary to stimulate the release of ACTH, and ACTH in turn would stimulate the adrenal cortex to release glucocorticoids, primarily cortisol. Now, obviously this stimulation needs to be controlled so that excessive rise in hormonal levels can be prevented. So this is addressed by a short loop negative feedback and a long loop negative feedback. So for example, when the anterior pituitary releases ACTH, this ACTH will then inhibit hypothalamus to prevent further release of CRH. So that's the short loop. And similarly, the cortisol released from the adrenal cortex will inhibit both the anterior pituitary to minimize further release of ACTH, and also it would inhibit the hypothalamus to reduce further release of CRH. So the long loop negative feedback acts at two levels, both at the level of the anterior pituitary as well as the hypothalamus. And these short loop and long loop negative feedback mechanisms help control secretions from the hypothalamus and the pituitary. And you can apply similar examples to understand the control of growth hormone from the anterior pituitary or some of the other hormones such as the luteinizing and follicle stimulating hormone. Now we shall discuss growth hormone in a bit more detail. It is also known as somatotropin or somatotropic hormone. And chemically it is a small protein with 191 amino acids in a single chain. The main function of the growth hormone is to promote growth in all tissues of the body, and it does so by increasing the number of cells and increasing the mitotic activity in the cells, thereby increasing the number of cells. The growth hormone exerts most of its effects via somatomedins or insulin-like growth factors, which are basically modified portions of the growth hormone in the liver. Somatomedins are particularly important in promoting growth in the skeletal tissues. The effects of the growth hormone in promoting growth are primarily related to its effects on the protein metabolism. Growth hormone increases the synthesis of proteins and reduces the breakdown of proteins, and it does so by enhancing the transport of amino acids across the cell membrane. It enhances both DNA transcription as well as RNA translation, and it spares proteins by reducing protein breakdown. Growth hormone has a number of effects on the fat metabolism. It increases breakdown of fatty acids from the adipose tissue and thereby increases the conversion of fatty acids into acetyl coenzyme A in all tissues so that the fats can be utilized for energy. It may also increase acetoacetic acid in the blood, which leads to ketosis and a fatty liver. The growth hormone affects the carbohydrate metabolism, leading to a decreased uptake of glucose by cells including muscles and adipose tissue. As a result, it leads to increased blood glucose levels, which in turn increases insulin secretion, and this increased blood glucose load may eventually burn the beta cells of the pancreas, which produce insulin. Increased growth hormone secretion thus has a diabetogenic effect and may lead to a type of secondary diabetes known as pituitary diabetes. We shall discuss this later in the disorders of the pituitary gland. As discussed in the previous slide, growth hormone secretion has a strong correlation with glucose and insulin levels in the blood. Growth hormone fails to cause growth in the absence of glucose or insulin. And another reason is that insulin promotes transport of amino acids across the cell membrane, and these amino acids are required for growth. So therefore, growth hormone secretion is coupled with simultaneous increase in insulin secretion. The rate of growth hormone secretion varies with age. Even though the rate of secretion decreases with age, it never falls to zero. During childhood and adolescence, the growth hormone levels in the blood are approximately 6 nanograms per mil, whereas between 20 to 40 years they fall to 3 nanograms, and after 40 they drop further to approximately 1.6 nanograms, and there is some research to support that this contributes to the aging process. During prolonged starvation, the growth hormone levels may rise as high as 50 nanograms, and they characteristically rise in the first 2 hours of deep sleep, and that is why children tend to sleep longer, because they need growth hormone for their growth in the early years. Growth hormone secretion is regulated by a variety of factors. Starvation, as mentioned in the previous slide, especially with severe protein deficiency, stimulates growth hormone secretion. Similarly, hypoglycemia, low concentration of fatty acids in the blood, exercise, excitement, and trauma tend to increase the growth hormone secretion. In addition to the factors mentioned in the previous slide, several hormones also influence growth hormone secretion. It is stimulated by growth hormone releasing hormone from the hypothalamus, the catecholamines such as adrenaline and noradrenaline, dopamine and serotonin, whilst the growth hormone secretion is inhibited by growth hormone inhibitory hormone, also known as somatostatin, which is primarily secreted by the hypothalamus, but also by the islet cells, the GIT, the CNS, and some other tissues. The most remarkable effects of disorders of growth hormone secretion are observed if this occurs during childhood or adolescence, that is before the closure of the epiphyseal growth plate in the long bones, which normally occurs around 12 to 16 years in females and 14 to 18 years in the males. If the growth hormone secretion is increased excessively during this period, it leads to a remarkable increase in the height of the individual, a condition known as gigantism. Conversely, if the growth hormone secretion is reduced, it leads to a remarkably short stature of the individual, as depicted in the image. Hypersecretion of growth hormone after closure of the epiphyseal plates in the long bones leads to a condition known as acromegaly. As opposed to gigantism, acromegaly is associated with a less marked increase in the height of the individual but manifests with increased thickness of the bones and the soft tissues. In the head and neck region, the features of acromegaly include mandibular prognathism, spacing of teeth, and increased size of the tongue known as macroglossia. Similarly, the salivary glands may also increase in size, a condition known as sialosis. Hypersecretion of hormones from the anterior pituitary may have several other effects. For example, increased levels of growth hormone cause hyperglycemia and stimulate insulin production. Eventually, the insulin cells may burn out and lead to a secondary type of diabetes known as pituitary diabetes. Similarly, increased ACTH production from the anterior pituitary causes excessive release of mineralocorticoids from the adrenal cortex, which may lead to a rise in blood pressure or hypertension. Finally, increased TSH levels may lead to excessive stimulation of the thyroid gland, leading to an increased size of the thyroid gland, a condition known as goiter. Deficiency of pituitary hormones may lead to reduced stimulation of other glands. For example, a reduction in TSH excretion by the anterior pituitary may lead to hypothyroidism, and similarly, reduced excretion of ACTH from the anterior pituitary may lead to a reduction in the production of adrenocortical hormones known as glucocorticoids. As a result, the body may not be fully capable to respond to conditions of stress such as trauma or major surgery. Reduced level of blood glucose and a reduction in blood salts may contribute to hypotension and produce a state of shock known as adrenal crisis. Now we shall look at the hormones secreted by the posterior pituitary gland, also known as neurohypophysis. The main difference between the hormones secreted by the posterior pituitary as compared to the anterior pituitary is that the hormones in the posterior pituitary are not synthesized in the posterior pituitary gland itself. In fact, they are synthesized by the hypothalamus and then transported through the hypothalamic-hypophyseal blood vessels into the posterior pituitary, where they are stored for future secretion. The posterior pituitary gland secretes two hormones, oxytocin and the antidiuretic hormone. These hormones are initially synthesized in the hypothalamus and then transported to the posterior pituitary for storage and secretion. The supraoptic nucleus in the hypothalamus is primarily responsible for the synthesis of oxytocin, and the paraventricular nucleus in the hypothalamus is primarily responsible for synthesis of the ADH. However, each nucleus is capable of synthesizing both hormones independently. Oxytocin is a peptide hormone synthesized in the cell bodies of the hypothalamic neurons and secreted by the posterior pituitary as mentioned before. Oxytocin has two main actions. Firstly, it powerfully stimulates the contractions of the gravid uterus towards the end of gestation, promoting delivery. Secondly, it helps expression of milk from the breast alveoli into the ducts, facilitating the suckling process. However, it does not have any direct role in breast development, which is a function of prolactin, as mentioned before. The second hormone secreted by the posterior pituitary is Antidiuretic hormone or ADH. It is synthesized as a pre-prohormone and processed into a nonapeptide. The ADH is synthesized in the cell bodies of the hypothalamic neurons and stored and secreted from the posterior pituitary or neurohypophysis. The main action of the antidiuretic hormone is to conserve body water and regulate tonicity of the body fluids. ADH increases reabsorption of salt-free water from the distal renal tubules and collecting ducts, thereby preventing the loss of water and production of a concentrated urine, a phenomenon known as antidiuresis, which provides the basis for the name of the hormone. At higher concentration, ADH also constricts arterioles, which is why it's also known as vasopressin. The antidiuretic and vasopressive actions of ADH are particularly important in conditions associated with hypovolemia, such as loss of water from the body in dehydration or excessive loss of blood from the body. This slide depicts how a reduction in plasma volume stimulates ADH secretion. Reduction in plasma volume may result from excessive loss of water, such as during persistent vomiting, diarrhea, or excessive sweating. Similarly, hemorrhage may also lead to loss of blood and plasma volume. Reduction in plasma volume in turn leads to a reduction in venous pressure and venous return to the heart, and a reduction in the atrial pressure is sensed by atrial baroreceptors, which reflexly stimulate the excretion of ADH. The increased ADH excretion in turn leads to reabsorption of water, restoration of plasma volume, and the blood pressure. So now you can understand the hemodynamic control of ADH excretion, as you would have sensed that ADH excretion is stimulated by a decrease in blood volume or plasma volume, a reduction in cardiac output or blood pressure, and hemorrhage is a potent stimulus of ADH release. Activities which reduce blood pressure increase ADH excretion. Conversely, activities or agents that increase blood pressure suppress ADH excretion. Because whenever ADH excretion would be increased, it would lead to expansion of the plasma volume, and at higher concentrations, it will have a direct effect on the arterioles to raise the blood pressure. This slide depicts the correlation between percentage reduction in the mean arterial pressure and the plasma ADH levels. And you can see clearly that a reduction in the arterial pressure leads to a linear increase in plasma ADH levels. In other words, a reduction in the arterial pressure is a potent stimulus for ADH secretion. ADH deficiency is one of the most recognized disorders associated with the posterior pituitary hormones. ADH deficiency may result from head injuries and leads to a condition known as diabetes insipidus. This is marked by an inability to produce a concentrated urine due to lack of reabsorption of water in the kidneys. As a result, there is excessive loss of water from the body, resulting in polyuria, hence the term diabetes insipidus. Dehydration resulting from diabetes insipidus may also produce dryness of the mouth, which is known as xerostomia. Xerostomia may lead to several complications, in the oral cavity, including oral thrush, root surface caries, difficulty in mastication, swallowing, speech, and wearing prostheses and orthodontic appliances. To summarize, a variety of hormones are synthesized and secreted by the anterior pituitary gland. The hormones of the anterior pituitary in turn are controlled by releasing and inhibitory factors from the hypothalamus. The hormones of the posterior pituitary, on the other hand, are synthesized in the hypothalamus and stored and secreted by the posterior pituitary gland. It is important for you to understand the actions of each of these hormones, their regulation, and common disorders associated with secretions of the pituitary gland. The next slide provides you with a reading list to consolidate your knowledge during self-directed learning. Thank you.